So, welcome everybody to this poster competition. So we have a very strict jury here with Vinod Turani, Samir Kapadia, Jose Pomar, and myself, Marta Sitges. And we will change a little bit the order because one of our competitors has to leave. So remember, you have only 2 minutes for presentation. We will be very tough with that, and we will have 1 minute for discussion. So the first presenter will be Ufuk Baldan, and the title of the poster is Double Valve Surgery in Infective Endocarditis, Mitral Valve Replacement versus Mitral Valve Repair.
Yeah, I'm going to set a timer, and then you'll hear it go off.
Okay, fine. That should be good. Okay, good afternoon, everyone. My name is Ufuk Baldan. I'm a resident and a PhD candidate in cardiothoracic surgery at Amsterdam UMC. Today I will keep it short while I present our data about double valve surgery in infective endocarditis. Well, let's get straight to the matter. We all know that double valve surgery is a surgical headache, and we all have that one intern or resident is saying during the pre-op meetings, well, shouldn't we replace the mitral valve instead of repairing it to shave off some time of the ECC and AOX? Well, the answer to that question is most of the time, well, bad repair is non-inferior to a replacement. But what does our data say about the time? Well, between January 2015 and June 2024, we identified 82 patients who underwent a double valve procedure concerning the mitral and the aortic valve with an in-hospital mortality of 10%. Well, we all know the alternative is less appealing. But if we look to the heart of the matter, to the times of the mitral valve repair and replacement, we see that if we do it with concomitant with an aortic valve replacement, the AOX and ECC times are almost the same. But if we look at if you're doing a root replacement in addition, suggesting it's a more extensive disease, we see almost that the AOX time, the ECC, doubles in time. But most importantly, we see between the mitral valve repair and the replacement, we see a difference of 1 hour. However, what can you conclude out of this? If a repair is faster than a replacement, but there are 2 things we have to keep in mind. 1, the extent of the disease, and 2, the surgeon's expertise and experience if you have with such cases. In conclusion, if you can do it and it's feasible to do a mitral valve repair, just like Nike says, just do it. And in other cases, you can get away with the replacement. Thank you for your time.
So your conclusion reads that we should do mitral valve replacement more than repair? That's what the first thing says? Demonstration lower mortality compared to
repair. MVP is repair.
MVP.
So repair better.
Repair better.
Exactly.
And do you have long-term follow-up on the reinfection rate?
No, I don't have it. No.
So, I mean, as a surgeon, when I see these patients, honestly, if it's I don't know how you really, it's a little bit goofy conclusion, right? If it's an easy repair, if it's an easy P2, you're going to do it. But if it's got P1, P2, P3, there's destruction of the leaflet, now you're going to try to replace it, right?
Yeah.
So I think the conclusion almost to say, if it's a straightforward, easy mitral valve repair, but the worst thing that you can do in these patients, because I see a lot of this, is to do a complex repair, then do an AVR, then open the clamp up, you see a lot of leakage, and then recross clamp.
Yeah.
That becomes an issue. So I think that it depends on the type of repair you're doing. What are your thoughts about that?
Totally true, and we haven't further specified how many patches they were used or how extensive the disease was.
And these are all degenerative MR or functional MR? Because I couldn't tell from the
Endocarditis.
Endocarditis,
These are all endocarditis.
Endocarditis patients. Yeah. Any questions from the audience?
Maybe another reason for earlier surgery, a kind of, shortening the time for this tissue destruction, or
well,
probably no big difference, no, because these are short time, I guess.
Yeah, exactly.
I also didn't see the number of commandos you did there.
We haven't further specified it.
Okay.
But you can suggest that maybe if you're doing a replacement and concomitant with the root replacement, the disease is more extent. It's more likely that they did an extra additional patch to rebuild the central fibrous body.
That's exactly right. So, that's why I'm saying that sometimes replacements is a faster, better way that you don't have to recross clamp. So automatically, it's geared against replacing those valves. So I think if it's a straightforward P2, that makes sense. But I'm telling you, there's recent data that all this anterior leaflet work with repairs may come back within 1 to 2 to 3 years, and then you're stuck with a redo. Very good. Yeah. Thank you.
Okay, thanks.
So we move to the next one. So we'll follow the pre-scheduled order now. So the next one will be characterization of polycarbonate-based polyurethane for synthetic mitral valve prosthesis. And the presenter will be Farhad Sadeghi from University of California, Irvine.
Are you here?
Show up.
Or Arash.
Somebody?
One of them is.
Arash Keradavar? Okay.
In 3 minutes.
No show up.
Okay, good.
No show. So.
Dennis
Next
is
one.
here. I saw there's Dennis. Yeah.
Dennis is here, yeah.
So just
So Dennis Bouchard from Montreal Heart Institute in Montreal, in Canada. Contemporary 3-year real-world outcomes following mitral valve replacement with a novel mitral tissue bioprosthesis. Yes.
Do we need it, the bottom thing down there? Is that what that is, the bottom arrow? See the bottom arrow next to M17?
next
Okay.
slide. Yeah. Just next slide. Do it. Yeah.
Yeah, down there, Dennis. The other way.
The other way. And this is Arabic way. This is.
Good.
No, because you went the other way.
Yeah. You got to go to the right. Arrow to the right. Right? I think it's the arrow to the right.
Arrow to the right, because Arabic way is left.
Yeah.
Yeah.
Super.
So I'm presenting on behalf of the Montreal Heart Group and my colleagues. So after having introduced Inspirus with the Resilia technology for the aortic position at the Heart Institute, we were enthusiastic to start our experience with the MITRIS, biological mitral valve prosthesis. We started in July 2021, so the valve was available in Canada a bit earlier than in the US and in Europe. And we have been reviewing here on this paper what has been the early results from the introduction in July 2021 up to March 2024. So in that period, excluding the patients that are part of the Momentous trial, we end up having 247 cases, consecutive cases of MITRIS implant. Here you have a bit of the demographics. They were quite morbid patients with a calculated SCS score around 7%, and 3/4 of them being in the advanced functional class. Almost half of them were done through MIS. The other part of the cohort were combined with other procedures. The average sizes we used was 29, with also a large number of 27. Even though this is a tissue promising better durability, all our indications remain a bit more conservative, with the largest populations being between 70 and 80, but with a certain amount in the 20% range, 60 to 70 and below 60. We were very careful of looking at valve-related complications. We had 6 patients that unfortunately had a stroke early on and 1 later on follow-up. There was no cases of valve thrombosis. There was an early and a late endocarditis cases, no PVL, and no non-structural valve deterioration cases. We had great hemodynamics up to a year. Now the late follow-up echo is all at 1 year. The gradient is stable at 4.
I think excellent information, but do we know that the mechanism of stroke or anything like that to say if there's valve thrombus there, or whether you did a CT scan or something, or their AFib?
Yeah, I don't have here the precise information of the strokes, but none were deemed to be clearly newly thromboembolic, but those perioperative strokes, they could be aortic clamping, it could be air, it could be particulates from the valves, but we have none that seems to be associated with an echothrombus on the valve.
So David's question, I usually, for these mitras, just talk about your sizing. 27, 29, you said, I think, is the most common for you. I'm commonly using a 31, 33 for these. Just tell us, are you undersizing? Are you planning on it? Are you oversizing? Are you true sizing? Because a lot of these patients with MR have already huge LAs and they have a large annulus. How do you size these? Because I'm putting in different sizes than you are.
Yeah, well, that's a very good question. I would say, if anything, we upsize a bit. Because the prosthesis come with the struts folded in at 55 degrees, it's sort of easy to push a bit of a larger valve. So these are true with a tendency to the upsizing that we have seen, but that's a great variabilities of patients. Some of them are failed mitral clip, some of them are rheumatic heart disease, some of them are functional MR. But we tend throughout the years to see less and less functional MR coming straight for mitral valve replacement. We would most likely do HOS therapy on both of those.
Okay, great, thank you.
So pre-op, that whole population, 66% were already on anticoagulation before the procedures, and at the latest follow-up, around the same number of patients were still on on anticoagulation. Because some were quite elderly, we choose not to reconduct anticoagulations electively, So most of them were on their pre-op indications for anticoagulations. We would not put a 75-year-old woman on new, just for the bioprosthesis protections on anticoagulant, but we would probably do that on a 50-year-old man or woman coming at a younger age group to prevent valve events.
Great, thanks.
Great, thank you. So next one will be presented by Ignacio Niosi. He's here on behalf of an international group of people from Italy, Germany, Pittsburgh, that's it. So the title is In Silico Multiphysics Model to Assist Biomimetic Polymeric Mitral Valve Double Component Deposition Processing. So let us know.
Okay. Good afternoon, everyone. My background is biomedical engineering, and I will talk about the optimization of biofabrication of a tissue-engineered mitral valve with electrospinning technique. As you know, engineering the mitral valve poses unique challenges because of the asymmetric properties of the mitral valve and functional also properties. For this reason, in the state of the art, the fabrication of tricuspid and mitral valve are based on single leaflet fabrication and that are assembled post-processed, and the suturing points could represent a failure. So the fabrication of incontinuous material scaffold is today not reached. For this reason, we exploit a technology, patent technology that is called double component deposition within the electrodeposition, the electrospinning technique, where a combination between conductive and non-conductive material that create the overall shape of the collector were tested and analyzed through an electrostatic numerical simulation in order to identify the best target collector in terms of electrical field homogeneity. After that, we moved towards the in silico analysis of for the identification of the fabrication setup, and we ran some aerodynamic simulation in order to identify the needle position in order to achieve a functional anisotropic leaflet. After that, we were able to, so thanks to the double component deposition in the electrostatic simulation, we optimized the thickness distribution. There is a critical parameter for the stress distribution in the valve, in the bioprosthesis, and we, thanks to the aerodynamic simulation, we were able to identify the setup to achieve the target anisotropy, both in terms of micro and microstructure and functional anisotropy. So the anterior leaflet was compared, the analysis obtained from the engineered leaflet were compared to the ones obtained from the native leaflets, and we can say that we can closely match these parameters, especially the anisotropic ratio that characterize the anisotropic level in the leaflet, and the orientation index that characterize the fiber of orientation of the collagen fibers for the native tissue and the electrospan fibers for the engineered leaflets. Thank you.
Thank you. So, how are you going to implement these findings in the development of a new prosthesis? I mean, is it ready to go?
Actually, there is another part of the team that is focused on the development of the corde, because the project is based to have a biomimeric mitral valve with a set of corde that will be implanted without any stent. So thanks also to the electrospinning process, there is multi-stages that focuses on the fabrication of the anterior leaflet, the posterior leaflet, and of the annulus. With this approach, we are able to obtain an incontinuous material valve where the annulus could be, tuning the time, the deposition time could be thick as a common Dacron ring. And actually, yes, we already have a plan to implant this device starting from September 2025. Annual model ship. 25. Yeah, I'm going to have a massive summer for the fabrication of valves.
Thank you very much. So, next one will be Takenori Kojima from Japan, who will present a case of mitral valve repair for mitral regurgitation due to double orifice mitral valve. Please. Oh, we need to change this, no?
Yeah, that would, so he can do it.
Takes time. Okay.
Thank you for the opportunity to present the case of mitral valve repair for mitral regurgitation on double orifice mitral valve. The DOMV is a rare congenital cardiac anomaly characterized by two separated mitral orifices, and each orifice has its own parachute-like subannular apparatus like this, which means cardiac tendon arising from a single papillary muscle to each orifice. Our case is a 60-year-old woman, with no history of congenital heart disease, presented with nocturnal dyspnea and diagnosed with severe mitral regurgitation. And a transthoracic echo showed abnormal mitral valve motion and severe regurgitation on the lateral side, but the DOMV was unclear. On transesophageal echo, there was a central fibrous bridge and two separated orifices. It is revealed with DOMV. And on the lateral side, there was a prolapse area which is called a rupture. And also this is operative findings. We performed minimally invasive mitral valve repair, and this showed the bridge and two orifices, and major orifices was rupture. And on the lateral side, and called the rupture and prolapse area was shown. And each orifice has its own papillary muscle and parachute-like caudal structure. Our repairing technique was mainly using the artificial coating, CV4, and the prolapse area was repaired with plication of cleft or indentation area suturing. And the postoperative echo showed no regurgitation and stenosis. And two takeaways from this case. The first is about the diagnosis. The TEE isn't recommended, but recognizing the subvalvular apparatus, trans-thoracic echo is still useful in diagnosing the UMV. And the other is about surgical tips. The operative strategy was not different from that for normal office mitral valve, but avoiding a postoperative MS is crucial. So excessive plication or excessive annulus narrowing should be avoided, especially in the UMV repairing. Thank you very much.
One question, the approach was minimally invasive?
Yes.
How about a CT scan? You think that the CAT scan would have helped you to diagnose the problem a little bit better? Or?
Oh,
The subvalvular apparatus in particular, because sometimes the TE, it's harder to see the subvalvular apparatus. So CT scan.
Normal CT scan, so CT doesn't reveal the UMV on our CT scan, but like for the CT or CMRI could be useful, I think. Thank you very much.
Great job. Thank you. Okay. So next one will be presented by Mark Gilinov. I don't see him.
I don't see Mark.
Anybody from?
I saw him earlier this morning, but
Okay.
I haven't seen him
But
since
I don't
then.
know what this is.
It's a case, looks like a case.
Case,
Yeah. Let's move to the other one, presented by Shipra Shivrastava. Yeah. So from India and also from New York, a rheumatic mitral valve repair, the SHIP technique, excellent results in aggressive mitral valve disease. Please.
The microphone down a little bit too.
Yeah, take it to the side.
Oh,
Those arrows, I don't think the arrows work, is that right?
the arrow. I know, but it's here.
Yeah.
This poster.
It should be the one after the,
One
no?
more?
Muhammad. Yeah, it should be one more after that.
The first one was.
That's Muhammad, and then do the, hit the right. There, this should be it. One more.
One more?
Yep. Oh, great.
Okay, this is yours.
Shipra.
No, she likes it this way because otherwise.
Yeah, I can stand here.
Yeah.
Good evening, everybody. So I will not take much time because I have a limited time. The commissures play a vital role in the hinge mechanism of the mitral valve, which is often underestimated by the surgeons. So in rheumatic repair, surgeons often tend to perform limited commissurotomy that gives rise to sometimes significant residual gradients and even may compromise with the mitral valve area. Extended commissurotomy gives always post-operative residual leak and the leaflets can become flail. So after a couple of modification, I derived this technique of commissure reconstruction. So I do extended commissurotomy in one of the commissures and the commissure which is more fused is chosen for the commissure reconstruction. A kite-shaped pericardial patch is harvested, which is pre-treated with 0.6% glutaraldehyde for about 1.5 minutes only, and the points are marked as A, B, C, D, and E. From point A to B is sutured to the anterior edge of the commissurotomy, and A to C is sutured to the posterior edge. The point D is chosen to place one or two pairs of commissure neocords. And from the point D, we make a patch commissurotomy. So this procedure gives like a complete commissure reconstruction, and it achieves type 1, and we get excellent diastolic opening, a very good systolic closure. It reduces the stress on the leaflets because it is more flexible now. It supports the mitral apparatus because it has 1 or 2 pairs of commissural neocords, and also gives rise to excellent mitral valve opening area because of patch commissurotomy, and also ensures a laminar blood flow across the mitral valve. And so far we have got very good result with this technique, and one patient is described here with a significant gradient of 51, area of 0.5. With our technique, we could achieve good result with mean gradient of only 2.9 millimeter mercury and excellent mitral valve opening area of 2.4 centimeters square, and the PA pressure is also reduced from 120 to 60 millimeter mercury. Thank you so much. And this name was derived because it sails effortlessly in both systole and diastole. So both the leaflets, they get support of the commissure reconstruction. So,
And this is why it's called the ship?
yeah, that is the reason.
Thank you. That was going to be my question. Thank you very much.
Thank you.
Questions? Any question now? Surgical question?
No. I mean, it's nice that when we see a lot of these repair patients in MS, I've yet to see very good long-term data, honestly. Everybody does a great job getting the patient out of the operating room, and I commend everybody for doing that, but I've never seen 1 year, 5-year data of good echo data. I think that's really got to be something that it would be nice that for in the future, people present these cases and say, here's the echo at 2 years. To me, that means a lot more than doing it and saying it's good for 30 days. 30 days is not good enough for a 60-year-old. It should be 3-5-year data. So in the future, it'd be great for those people who submit cases to say, I did this case 5 years ago and look at my results now. To me, that's more meaningful. Thanks. Yeah, that's great. So next year in Chicago, we expect a poster on that.
You're invited to Chicago next year, and you show us the long term. Great. Thank you. So next one is Flaviana Falci. Nobody on behalf of the group? No? Okay, so we move to the other one, which is Cristian Muñoz, which is here from Spain. Transcatheter mitral valve replacement with Tendyne, early Spain and Portugal experience, the Iberian registry.
Dear Chairman, dear colleagues, it's a pleasure for me to present here the Iberian Registry of Transcatheter Mitral Valve Replacement with Tendyne. As you all know, Tendyne is the only CE mark approved transcatheter mitral valve for its use in Europe since 2020. This Iberian Registry was a registry of the initial experience with the Tendyne valve across 7 centers in Spain and Portugal from December 2020 to June 2022. 40 patients were included with a mean age of 78-year-old, all of them deemed unsuitable for surgery or transcatheter edge-to-edge repair, and with a mean SDS score of 5.3%. Preoperatively, 75% of these patients were in functional class 3 or 4, 30% of them presented with prior valve interventions, and interestingly, 20% of them were performed under an off-label indication, including MAC, the presence of a prior mitral ring, or the risk of LVOT obstruction. Although all of these complexities, technical success was recorded in 100% of cases with no conversion to open surgery or no intraoperative deaths. And at 1 year follow-up, the most important findings were that all-cause mortality was 17.5%, that 94% of patients presented with residual MR grade 0 or 1, and that 84% of patients presented at 1 year follow-up with functional class 1 or 2. In conclusion, transcatheter mitral valve replacement with Tendyne is a safe and effective treatment in this high-risk population with important clinical improvements at 1 year follow-up. Thank you very much.
That was excellent. Thank you for being on time. I presented the data for Tendyne in the U.S. last year at TCT, and your results are outstanding. So I'm very complimentary of your results at 2.5% mortality at 1 month is absolutely great. What I'd love to know is that 17%, a lot of these patients are sick patients. So what would be very nice to know is this cardiovascular mortality of 17%, or is it really non-cardiovascular mortality? I'm interested in knowing that.
This was all-cause mortality. When we analyzed cardiovascular mortality at 1 year was 6%.
Yeah, so that's spectacular. And I think that's, in your future presentation, you almost want to do that as a caveat and say that there's a very large non-cardiovascular mortality at 1 year, which is common in these patients. So phenomenal outcomes, and really, this is spectacular.
Thank you very much. After the preoperative CT scan, we decided to go with a balloon valvuloplasty or not. Mitral stenosis is difficult to address with this valve, but if the stenosis is rheumatic and we find commissural fusion, we try to open but this has to be preoperatively prepared. We opened the valve with balloon valvuloplasty and then we implanted the valve.
Great.
Thank you.
Thank you.
Thanks, Christian. Yeah, so we move to Dominic Eng from Australia. You're here? Okay. So it's a novel bioprosthetic mitral valve for valve augmentation, OVINE studies. Dominic, hello.
I'm not a Dominic.
No, you're not
but
Dominic.
I'm on behalf
Yeah.
of Dominic. Let me find the...
So what's your name?
No.
That one.
It was there. I'm sorry. 1 second.
So I'm Stan Yastrobov. I'm an intensive care specialist in a dangerous environment of surgeons. And
cardiologist.
So I work with a cardiac surgery group and cardiologists.
And
just having
researchers.
fun with research. No, different one. First. And G.
Next one. I think so. Just the arrow.
Here we go. That's it. So we investigated a new prosthesis. It's a bioprosthesis for the mitral valve that is being developed now in Sydney. There are several specifics about this prosthesis. One of those is that it's asymmetric in the annulus, more resembling the native one. And the second one, it's very low profile. The struts measure only 6 millimeters. So we decided to look at hemodynamics and biomechanics of this valve when it's implanted and what's the best position for that valve. And there were 6 ships that we were able to secure and fund. And we looked at supraannular position of that valve in 2 ships. There was intraannular normal position in 2, and the other 2 had intraannular malrotated position. We had full hemodynamic monitoring. There was a ultrasonic flow meter around the main pulmonary trunk for continuous cardiac output measurement and transapical Miller catheter pressure volume loops in LV. So the results are pretty straightforward. When there was supraannular position, there was absolutely no impairment of native anterior or posterior mitral leaflet. In intraannular normal position, there was normal transmitral flow, but when we also had the sutures put, which are releasable sutures around anterior posterior mitral leaflet to allow for leaflet to be effectively pulled and impaired. And when we did that, there was significant impairment in function of the left ventricle. And you can see it out there, both cardiac output and stroke work, and also all the pressure volume parameters of contractility were impaired. There was no impingement on anterior mitral leaflet, but the posterior strut impinged on the posterior mitral leaflet, causing moderate regurgitation. And in malrotated ones, there was significant impairment of the anterior leaflet by impingement of the struts, so position is very important. And as a result, we concluded that supraannular position is best. None of them caused dynamic left ventricular outflow tract obstruction. The valve is here if anybody wants to see it later.
Very nice. I saw this valve, but so apparently you do not remove in the supraannular position, don't remove the native valve, just
Correct.
put the valve
Correct.
on top.
That's right.
And what is the advantage is that you don't have to resect the valve and the...
That's exactly it. The whole idea is that anterior mitral leaflet is not impaired. Our group is specifically interested in IML, and it's a very important part of the mechanoenergetics of the left ventricle. Having it preserved together with subvalvular apparatus, not resected partially or completely, is very important.
I have a question for you. If we were to do a sapien valve inside this valve, and you have an anterior leaflet that's currently present, would you not get complete LVOT obstruction at that point? Let's say that, sometimes you have anterior leaflet valves that measure, and for whatever reason, they measure 34, 35 millimeters sometimes. And so if you don't resect it and you put this valve in, and then 10 years later you need to do a sapien valve, then you're going to have a 36 millimeter sapien valve, 36 millimeter anterior leaflet now that moves up when the sapien is deployed. Will you not have complete LVOT obstruction at that point?
Look, it's impossible to predict. We would need to test it in a similar model and see what.
So I would do that. Valve height is relatively small.
Yeah, but you still have to plant the sapien in there.
But again, put it in the atrial side. That's the concept.
Yeah.
So that, if you put the end of the sapien at the end of the valve, then you probably have...
I love the lower profile. The question is that I think you should also model in-sheet models after you've done that. And the sheet anterior leaflet mitral valve is, if I understand correctly, is much smaller than is the anterior leaflet of a human being. Am I right?
No, it's
Is it the same?
It's about the same.
Yeah, I know a pig, but I can't speak to the sheep, my anterior leaflet mitral valve.
And we do see the left ventricular outflow tract obstruction in sheep in various experiments that we do.
Yeah.
That's not unusual at
Yeah.
all.
I think that would be a next maybe thing to do is put a sapien in there and see what you get, because I think any tissue valve, you must expect that they will fail sometime, and a sapien is a very easy procedure to do that with. Great job.
Sounds good. I have one more paper. Yes, please.
The same question that I had. Yeah, super. Yeah, thank you very much. Good job.
Okay. So the second paper is related to the ischemic cardiomyopathy. As you know, that mitral annuloplasty is performed for that, and the outcomes are much better when it's done together with subvalvular procedures. And there's two subvalvular procedures are most frequently done. One is approximation of the papillary muscle.
Which one is this?
And another one is shortening of the papillary annular distance. And we decided to look at what actually those subvalvular procedures do to the mechanoenergetics of the left ventricle. So monitoring was the same as previously described. The model also involved placing a near cord on both papillary muscles with respective trigones connection through the pledgeted suture, which virtually became a releasable snare. I'll tell you details if anybody is interested about how specifically it was done. And that's for the shortening of papillary trigonal distance. And for the for the papillary muscle approximation, we used pledgeted sutures that went through the both papillary muscles and then transmurally out, so that we can pull them together and release, And we had 8 strip where we did shortening and 5 strip where we did papillary muscle approximation, looking at various parameters. So the results are that both of those procedures actually impaired myocardial function. Cardiac output went down, stroke volume went down, stroke work went down, more so with papillary trigonal shortening. We didn't have increase in end-diastolic pressure, surprisingly, but there was a trend. We just didn't reach statistical significance, probably just not enough shape, I would presume. So the conclusion is that those both procedures actually affect contractility, and they also affect hemodynamic parameters, although they are necessary for longer-term outcomes. Thank you.
Many years ago, there were people reporting cases where you were using two rings, one of the upper part, one of the papillary muscles. But honestly, I don't know about the long term of this type of procedure for the ischemic. Probably if you have been doing something similar, you have been reading all these papers. What do you think is?
Look, the relocation of papillary muscles virtually leads to the geometric changes of the left ventricle. We just didn't know, and that supports the mitral valve in future for a long time way better than to leave the ventricle being disshaped virtually by the chronic regurgitation previously. So what effectively happens here is that although longer-term outcomes are better when annuloplasty is supported with those subvalvular procedures, in the short term, it does impair ventricular function.
So, I'm sorry, you're saying to do it or don't do it?
Well, I think we still have to do it, but we have to be mindful that it does cause impairment of the left ventricle.
So if it's going to cause impairment of the LV, I don't want to do it.
Yeah, so it causes impairment in the stroke volume, no?
Correct.
Yeah, of course, you don't expect nothing on contractility because you're not damaging the muscle.
Well,
but of course,
actually it did, because our pressure volume analysis shows that there was decrease in
but what decreases is the stroke volume because you're reducing the volume, the size of the ventricle.
Correct,
so stroke volume is the combination of contractility and size of the cavity, no? So
But
contractility.
That's correct.
Curve, the pressure volume loop, the curves are a little bit flat.
Little bit, yeah.
In the pressure volume loops, what we saw is that there is definitely less assaults and obvious changes in hemodynamics, but there is still decrease in indices of contractility which are independent from volume. I think what happens there, and I can only presume, that to some degree papillary muscle approximation causes a degree of disshaped of the ventricle, particularly with shortening of papillary trigonal distance. It effectively becomes no longer a sphere and no longer a bullet type, but it's actually disshaped bullet with more narrow apex, where the papillary muscles are actually attached to the ventricle because you pull it up.
Okay, thank you. Cool, thanks.
Pleasure.
So the next one is Agneta Simionescu from the US. The title is Tissue Engineering Models for Mitral Valve Calcification.
Let's go. Okay. So the goal of this project is to develop a model to study that we can use to study modifications in mitral valves at cellular and extracellular levels under conditions that increase mechanical stress as well as accelerates atherosclerosis, like diabetes conditions. So our in vitro model is based on mitral valve tissue engineering. Our mitral valve has a scaffold which is obtained by decellularizing pig mitral valves, and we seeded endothelial cells and interstitial cells, valvular interstitial cells. And this construct was mounted in a bioreactor, in a mitral valve bioreactor, under high pressure and high glucose concentration. And the results, we did histology only for now. We detected modifications in cells, so some osteocalcin and also activation of cells and also stiffening of the tissue and some signs of calcification. We compared these results with an in vivo model based on Yucatan mini pigs rendered diabetic by alloxan infusion, and we treated with insulin to keep glycemia around 500 milligrams per deciliter. And again, we looked at activation of cells and signs of calcifications. We compared the two models, and we concluded that our in vitro model could mimic the conditions, the environment of mitral valves regarding mechanical and also biochemical properties.
That's what we have. Thank you. So the idea is to develop an in vitro model that mimics the in vivo model to test new tissue for valves.
Especially the cells, cells and the extracellular components, because we believe that especially diabetic conditions contribute to calcification, especially to annulus calcification. That's the big idea. This is just what we have so far.
And so I think this is a very interesting model. And so the question becomes genetically, or not genetically, but will you be able to, for instance, give SGLT2 inhibitors or something like that, or Forxiga or something like that, that has good diabetic control and decrease some of the calcification? That to me would be very interesting in the pharmaceutical point of view, how to move that away from decreasing calcification.
We will do that. That's why we like the bioreactor, because we can modify chemically, and we will look at all the diabetic characteristics like oxidation, reactive oxygen species, ages, formation. So we see how can we inhibit these.
By the way, I went to Furman University, so I know exactly where Clemson is.
Not many people, thank you.
Thank you. Thank you very much. Next one, Tomohito Nakashima from Japan. So surgical repair of isolated P2 prolapse in a single institution, comparison between resection and artificial chordal reconstruction.
Thank you for the introduction. We evaluated the outcome of leaflet resection versus artificial chordal reconstruction in patients with isolated P2 prolapse. At our institution, we traditionally performed triangular or quadrangular resection, but since 2013, we've adopted artificial chordal reconstruction. We reviewed 107 patients from 2010 to 2023. 36 in the artificial chordal group and 71 in the resection group, with no significant differences in baseline characteristics. There was no perioperative mortality in either group. At discharge, moderate MRO was seen in one patient per group, and mean pressure gradients were similar. During follow-up, 3.3 years for group A, artificial chordal group, and 4.5 years in the resection group. Moderate MR occurred in 1 case versus 8 cases, respectively. However, Kaplan-Meier analysis showed no significant difference. And no reoperation occurred in artificial chordal group. In the resection group, the freedom from reoperation rate was 93.4% at 10 years. In conclusion, artificial coronary repair for isolated P2 prolapse achieves comparable result in short and mid-term. And further follow-up may provide additional insights, and it could be of interest to investigate differences based on region types and the number of neocodes and material of characteristics. Thank you for your attention.
I'll ask him. Yep.
Thank you.
Good job. I'm sorry. I'm getting old now. And so which patient had one, you said there are two groups, the resection and the cords. You said there's one patient had, reoperation means nothing to me, honestly, because that means a patient may not want reoperation. So one patient had one recurrence of MR, the other group had 8 recurrences of MR. Which is which? The resection is 1?
Resection is 8.
So 8 patients with a resection had moderate MR,
Yes.
right? And then one patient with cords had moderate MR.
Yes.
Okay.
Exactly.
Okay, yeah.
Respect.
Yeah, in this series, yeah.
I could say select, no?
I would say, yeah.
Which one is best for each one?
Yeah, and it's just isolated P2 prolapse, no anterior, okay, yeah. Yeah, just P2.
Thank you for your comment.
Great, thank you, thank you.
Thank you. So let's move to the next one. Okay, Raul Vera. It's not Raul Vera. It's Maynard Palman. Yeah. Okay. So
Bottom arrow to the right.
starting a robotic mitral valve program, focus on safety and learning curve.
Yeah, select here. Yeah, but I think we have to skip one. It is probably not loaded, so just hold on. Just click
It's
on
not
one.
loaded, George? Maynard?
Yeah.
This is it.
Okay, that's it.
Maynard, is okay? Yeah?
So, good evening. Again, evening. So, this paper is going to be about starting a robotic mitral valve repair program, and going to focus on safety and then the learning curve. So, of course, in order to get the same result, we chose to get a robotic program because we wanted to have the same results as our conventional program. And this is accompanied by a learning curve. And in order to mitigate this learning curve, we constructed a dedicated robotic team, and we went to an intensive training program. We performed a prospective risk analysis in order to see which were the risks of introducing such a program. And then, after we've performed an intensive training, we performed the first 10 cases with a proctor. And this, the rest of the presentation is going to be on results. So there was an early conversion rate of only 1 case in the early series and 0 in the late series. If we look at postoperative reoperation, for instance, I will not discuss them all, we see that we have some postoperative reoperations for bleeding, but what's most important, and that's the center of this presentation, I think, the initial repair rate was 100%. We had no mortalities, no postoperative stroke, and no myocardial infarction. So if you then compare the first series of cases with the last series of cases, you see, as expected, a decrease in total operation time, a decrease in extracorporeal circulation time, and a decrease in cross-clamp time. And also, if you take a look at these patients, you see that they will stay in intensive care only 1 day, and the last 40 patients were all extubated in the operation theater. So to conclude, and it can be quite quick, to conclude, you can start a robotic mitral valve repair program in a center, a high-volume mitral repair center that has no port access experience. And you can do this with mitigating the learning curve by introducing a very good, how would I say, training program, and get a robotic mitral valve repair team that's dedicated to do this job. I thank you.
So I'm sorry I missed the presentation, but I've looked at the slides before. So the only question I have for you is cross-clamp time, right? So a 2 to 3 hour cross-clamp time for the robotics with some improvement in that. How does that compare to a surgical time that you believe that you would have had? So in my opinion, that's probably about a 60-minute cross-clamp time with a surgery, and here it's about 2 to 3 times higher.
Yes.
So just comment on that.
So this is not completely right. The figures are not completely right. I'm sorry for that. So we're now at the last 20 cases. So this is not going to be 4, but it's going to be 20 cases. The cross-clamp time is well below 2 hours, which is still significantly longer than my open times.
Yeah, I would imagine that there would be.
Yeah.
Sorry, Minda, just to clarify me, so you went from open chairs directly to robotics without mix in the middle?
Yes, that's correct. And if
you have many units in the paper, how many surgeons are doing the procedure?
only one. The issue is, in the beginning, we had some changes in the table surgeon, we had some changes in the operating team, and actually the largest progress we have made in reducing operating times, that has been done actually in the last, I would say, 20 cases. And now we're the total operation time is now 3.5 hours instead of the initial 6 that we needed in the beginning.
Yeah, that's great.
But what is important, operating times are important, clamp times are important, but what is important is that you are able to start a robotic program without mitral valve replacement, without mortality. And I think that's what we're all aiming for.
Yeah, that's exactly right. Good job.
Thank you.
Thanks.
So next one will be Masashi Hazuma from Philadelphia. Anybody? No? Okay. So we move to Doosan Kim from Seoul, Korea. Single institute experience of suboptimal anticoagulation management after an Onyx mechanical mitral valve replacement.
Is Elena Sandoval also here? Yeah. Okay, good. Okay.
Thank you. Good evening, ladies and gentlemen. I'm Dr. Im from South Korea. It is my pleasure to present this nice meeting. It is my first time participation. Today, I'd like to present my single institute experience of the suboptimal anticoagulation management after Onyx mitral replacement. As you know, the very beautiful study of the PROACT mitral, as you can see here, in spite of the reduced dose of the warfarin, simultaneous prescription of the aspirin from the 44 centers, more than, sorry. Oh, sorry. I do not see you. Yeah. More. So I want to show the.
Okay.
Yeah.
Yeah. Just leave. Yeah. Just leave it here.
Yeah.
Yeah. Okay. Thanks. Let me just do this. Okay. There you go. Thanks.
Can I open the
You can't
full screen?
No. That's it. That's it.
Thank you. Yeah. As you know, the PROACT mitral report, in spite of the reduced dose of the warfarin, there is no difference in thromboembolism, valve thrombosis, and bleeding episode. So, maybe we inform of these fact sheet, the bleeding is a major concern in spite of the limited dose of the warfarin. Major difference between the project mitral and my study format is the Asian, more older patient, a very limited number of patients, but for longer time or period of the study target. In spite of them, there are also the similar outcome result, as you can see. Thromboembolism, valve thrombosis is negligible. Only the major concern is the bleeding. So I think it is the bleeding is the bleeding episode recorded in very limited patient and repeatedly episode. So it is not dose-related event rather than patient-specific or the patient event, patient's condition-specific phenomenon, I think. So it is need to, I think my next study target is to which condition and which patient this bleeding is very severe phenomenon or not. So it is my conclusion. Thanks for your attention.
That was a good presentation. Just just want to make sure that I understand this correctly. You're saying it's okay to have an INR of less than 2.5. You're saying it's okay. Maybe 2.5 is fine, but I think that's slippery, right? So I don't think it's good to have an INR less than 2.0, right?
No, but they said 2.0, 2.5. So
Is
you
it
never
2
went
to 2?
less than 2.0 because now the indication is up to 1.5.
No, that's for AVR, not for MVR. No, this is MVR. This is MVR. So that's what I'm saying is that I don't think it's okay that's what I'm trying to figure out. Is it 2 to 2.5 or where do you sit the INR? So it can't be less than 2.5, right? Because less than 2.5 might be 1.1.
The recommendation is the 2.5. The other 2.5 is the recommendation. But in real situation in my clinic, near the 2 point, the real world is the less than the 2 point is the no problem. Even in the very long term, very stable. At the time, there is no event in the valve thrombosis and because the big some difference.
So the mean INR is 1.4.
Prescription
in a mitral.
to low dose dual anticoagulant, aspirin and psilocybin.
Yeah, I think it's just, it says, it's there, man, right above thromboembolism. The two events, the right above that says, however, suboptimal INR range was 78% of patients. The median INR was 1.4. So I think seems a little low to me for a mechanical mitral valve. Personally, that seems a little low to me. So I think the best way to look at it is some type of, exactly. I think I'm not sure we can say that we're okay with a 1.4 unless we have really good data, right? A lot of patients, yeah.
The real, the important issue is the bleeding, only the bleeding, So it is needed to more decreasing the INR level in there.
What is your lower limit? At what INR
I think in my opinion, 1.5 is reasonable. For the long-term stable patient, 1.5 is also reasonable.
I would say that's different than every guideline ever published in the world. But that's what, everybody's different. And I think the Asian population is also very different because of the food that they eat
and Asian is different. And low-dose drug is...
I think, Samir, I think in the U.S., we would not run a patient at 1.5 for a mitral valve.
And it says with aspirin or without aspirin and silostazole, because it is something like that.
Low-dose silostazole,
Okay.
It is the, antiplatelet, or kind of antiplatelet.
It's a triple.
So both of them?
All three.
Three, including...
Okay.
Thank you.
Thank you very much.
Very
Let's go
provocative.
to the last one. Thank you.
Oh, because of the last chapter.
So Elena Sandoval from Spain. feasibility and safety of an ultra-fast track robotic program.
Well, good afternoon or almost evening, and thank you for the next one. Thank you for the opportunity to present the next one. Okay, so enhanced recovery programs and fast-track programs have been developed to improve attention to the patient, reduce postoperative complications, and the ICU and hospital length of stay. And robotic surgery has proved a faster recovery with fewer complications. Thus, we consider it was suitable for a fast-track program, and we aim to investigate the initial results of our ultra-fast-track robotic program. What we decided to do is that we pick all our patients scheduled for robotic mitral repair. They had to fulfill a checklist, so they need to be younger than 80 years old with scheduled for mitral repair and be scheduled as the first case of the day. And there are a bunch of contraindications like severe LV dysfunction, pulmonary hypertension, neurological dysfunction, or renal replacement, preoperative renal replacement therapies. Patients underwent robotic mitral surgery. They were extubated in the OR, and if conditions remain acceptable, we fulfilled the ultra-fast-track program. They were transferred to the recovery unit for 6 hours, and then if the postoperative course remained successful, they were transferred directly to the floor, skipping the ICU stay, or in case anything changed during the postoperative period, patients were sent to the ICU as regular cardiac surgery patients. So when comparing the patients who underwent that ultra-fast-track line and patients who didn't follow that path, we see that patients on the ultra-fast-track program or protocol were slightly younger, mostly male, with lower cardiovascular risk profile burden, and especially the most significant part that was they were in a better functional class, as you can see here in the percentage of NIHA over 3 patients. Then we didn't find any difference regarding surgical time, so at that sense they were pretty comparable. The extubation in the OR was not 100% because we had a complication in one of the fast-track patients that couldn't follow that path. And we experienced 5 failed fast-track patients. One of them was the one that I recall that we had a complication that required conversion to sternotomy, and there was one difficulty in the protocol, but not in the patient itself. We had a patient who developed seizures after the surgery, so we transferred him to the ICU even if the CT scan was normal. And there was a patient who required exploration for bleeding. That's the reason we canceled the fast-track line. Results from the mitral repair were equal, and we saw a significant difference in ICU and hospital lengths of stay. So we concluded that despite the limitations of the study, it was an initial study with a small sample, it's feasible to start an ultra-fast-track program and without hampering mitral results or safety for the patient. And we need to further evaluate if there's an economic benefit in this, at least in our environment. Thank you.
That was a great job. I mean, great outcomes that you have. Congratulations. The only question I have for you is, a total of 15 patients had preoperative atrial fibrillation. Mm-hmm. And it almost, for me, if 100% of my patients who have preoperative atrial fibrillation, when I do a mitral valve surgery on them, 100% get a maze procedure. Because I'm looking at the left atrium, I'm staring at it, I feel compelled to do something for it. And you had 3 out of the 15 that actually had a maze procedure during the LA. Is it just harder with a robot? I don't do robot, I do minimally invasive, I don't do robot. 3 patients out of 15 actually got something done for their atrial fibrillation. Is it just harder with the robot? Is that the reason not to do it? Does that make sense, the question?
Yeah, sure. Okay. Your point is well taken. The thing is, like, it's not harder. I mean, as everything, it prolongs a lot the surgical times. And I didn't mention it, but most of those cases were totally thoracoscopic. Sometimes it's difficult to manipulate the probe. We are starting to do it more, and we are getting more confident, but sometimes it's more difficult to manipulate the probes inside.
That's why I agree with you. It is harder for me also, and so when I have a mitral maze, I commonly will do it as a sternotomy, and I give a nice, good maze, close the left atrial appendage, and do a good repair. So for me, I've switched a little bit. So just, that's how I do it.
Go ahead, Leonard.
On the same topic, AFib, the time between the surgery and the starting of the post-op AFib, because the patient is going home at 3 days, and what it happens, the patient is at home and
So we recheck if all those ultra fast track patients were readmitted, and we only saw 2 readmissions, and the 2 of them were due to urinary tract infections. So we know it happens at the 2nd and the 6th day, but we haven't been able to report, and they didn't seem to experience that. And in response to Dr. Thurani, we didn't perform the maze, but we closed the appendage. I just
Super, good, that's great, thank you.
The second run, you still did the fast track, because 7 patients had 2 clamps, second clamp.
Yeah, in order to optimize the repair, it wasn't.
So it must be a long cross-link time, but
The cross-link times are phenomenal.
No, I
61,
see
63.
that 7
it's
people
phenomenal.
had 2 times.
Yeah, that's just great, that's good, that's very fast and very good, honestly. It's great results.
Thank you.
Thank you. So thank you very much. So thank you very much. We close the session here, and the winners will be communicated tomorrow. Thank you very much. Enjoy the evening.
There's also a reception that we're missing.
enjoy the
So there's a
reception.
reception at the main area. Thanks.